wonderful PowerPoint to really educate them on the device that we're planning to use, and how they can best avoid complications at home. All right, so I'm most concerned about complications, so I'm going to avoid it. So here we go. Here is this kid. He has a terrible hip. I'm going to try to lengthen him 7 centimeters. I know this is going to be a problem. I am preparing myself for the worst, but I'm going to really try for the best. So we lengthened him, and we were actually successful in not dislocating his hip. A miracle. He was so happy. His legs turned straight. I did do a derotation around the nail, and he looks good. But I guess I didn't prepare the village perfectly, because when he was finished lengthening, his father asked me if he could ride this hoverboard, which is probably the most dangerous toy out there. They stand on this, it's got wheels, and they crash all the time. So when Dad asked me, oh, he received this for Christmas, when can he ride it? I responded, never. Never, never, never. If he falls on this hip, we are done for. So anyway, I've given you about 40 slides on preoperative planning. I think this is the most important thing. You need to know what to expect the unexpected, and plan for both the worst and the best. So now we're set to go into the operating room. We need to flatten the curve intraoperatively. So there are a number of goals to consider. We need to protect the joints. We need to build a stable construct. We need to maximize our regenerative quality. We really need to perform a safe osteotomy or corticotomy. I want to my best ability, avoid pin, track, and wire infections, or at least prepare the family on what to look for. We need to avoid soft tissue restraints and achieve our preoperative plan. I'm not going to discuss the techniques today. There are obviously many ways that you can skin a cat, and many ways that we can perform these deformity corrections. But we need to stick to the principles. As Elizarov stated, we need to create a non-displaced fracture with a sparing corticotomy. We need to preserve that endosteal and periosteal blood supply. We need to minimize heat generation, really reduce our amount of periosteal stripping. Soft tissue releases as needed, not after they are needed, but before they're needed. And don't forget that sagittal plane. It is just as important to notice as the coronal plane. I had a friend who was so excited to use one of our lengthening nails, and she trained in fellowship with me, and she wanted to make sure I knew that she had put this nail in before I did. And I said, oh, so did you release the IT band for your lengthening? And she asked, no, why? So if you don't know all of the principles and you don't apply these, trouble can happen. So although she got to put the nail in first and lengthened her patient, I was very concerned that she hadn't stuck to the principles. So please try to avoid issues. So we know that subluxations and dislocations are often difficult to treat. By testing the soft tissues and releasing as needed preoperatively, or at the beginning of your case, or even at a different day, many challenges can be avoided. Moderate knee instability can be bridged with external fixators. Remember that congenital problems are often more difficult and challenging, but fun to treat than post-traumatic. Not all the time, though. So compartment syndrome is also a risk. Just to realize that even that with IM lengthenings and tibial osteotomies, this can be a problem. Prophylactic anterior fasciotomies of the tibia may help avoid the compartment syndrome. So this is another case. This is a child with congenital femoral deficiency. He's about 11 in this first picture. He's been treated for hip dysplasia in the past. There was preparatory surgery performed by the esteemed Dr. Thacker. He did a VDRO, he did a relative neck lengthening, and then after this had healed, he prepared for the first intramedullary lengthening. So everything was going great. He lengthened about 1.6 centimeters. The hip was looking good, no problems, but then something happened. Somewhere between the 1.6 and the 3.7 centimeters, the hip started to subluxate. So you can't continue. You must stop. Don't blast through this. It will not work. You will be in really bad straits. So he smartly took this nail back, shortened it by about a centimeter. The hip stationed a little bit better, and he stopped lengthening. And this doesn't matter if you're using an external fixator or an intramedullary lengthening device. It really shows that even though he had done preparatory surgery, the Degas osteotomy was just not enough to hold that femoral head. So therefore, a triple innominate osteotomy was performed. No more lengthening was suggested, and the epiphysiodesis was done on the other side. So here's another congenital case. This is a younger child. She's about 10. She has multiple problems. You can see that her hip is not beautiful. She had bilateral hip dysplasia. It was treated more like a DDH, which is probably not the diagnosis in this case. She has congenital femoral deficiency. She also has that valgus knee, and if you look to the right, I wish I had a video of this, but her knee is grossly unstable. So we are not going to make this mistake again. So we made sure we did a pretty substantial preparatory surgery, but she took forever to heal. Remember when I talked about patient selection and knowing the modifiable and non-modifiable factors? These are super important for this. You can see that there's a broken screw in the bottom x-ray. This is because this really took until I threatened the bone with the bone stimulator. She came in to pick it up about 10 months later, and the darn bone had healed. But her vitamin D level had been very low, and I made sure that I pushed for that every time, but the family was just not as receptive. But once they got on board and started to replace her vitamin D and feed her better, we did make some progress. But I haven't addressed the knee yet. She's young, and that will happen next, but I will have to address the knee before I begin to take care of that 6.5 centimeter lengthening. So principles of building a stable frame. Don't forget your principles. I feel like I'm speaking to the choir here. Know the anatomy, the stability. You want to make the bone as stable as possible. You want to look at the frame to bone distance, the ring diameter, the working distance, pin spread, fixation points. All of these are so important for when you address the modern US player. So you can see, if anyone has ever trained here, they know Dr. Bowen. This is what we call the Dr. Bowen special. Dr. Bowen likes to drop off patients at your door. I just want you to meet her or him. I just want you to say hello, and then you can take care of this fine young man. So anyway, that's usually right at the last patient when clinic is about to finish, and here is your next adventure. So one thing to look at in this pre-op planning, number one, he is very large. He weighs about 415 pounds, so what is that, 200 and something kilograms. Don't try to get both legs on one x-ray film. You will get poor quality films. You need to get I prefer a sagittal profile in full extension, so I know what bony and soft tissue components there are. And the patella is forward. So what is stable? I thought I'd put on a pretty nice frame here. I did my temporary arthrodesis. I had 4 half pins. I think I had 3 half pins and a wire up top. Well, maybe this one wasn't stable enough for this fine young man. So I think I could have changed a few choices. I could have considered double stacking my ring proximally. That is a 3/5 ring. Maybe it was not strong enough to support his weight, but I was afraid of, or I would prefer not to drop that osteotomy too low. But honestly, more translation for him wouldn't have mattered because it would have been hidden by his body habitus. I do make sure that I work very hard on how I put my pins in to not generate any heat. I use the biggest pins I can. I think I'll do a little bit better too about angling it in the predicted deformity direction. So here is some other ways that we can flatten the curve. How we place our half pins, as you just saw, is actually important. One bit of advice is that you can anticipate what your angulation deformity is going to be when you're lengthening or correcting. So you can put your pins or circular rings at 5 to 7 degree, at a 5 to 7 degree angle opposite to the expected angulation. The pin coating, it matters in order to help stabilize the pin bone interface. I also use a hydroxyapatite coated wire now, and my pins generally have HA coating well past or well onto the shank, so that there's much exposed HA, and I hope that it's forming a better biologic bind. But the research has not borne out that it decreases infection. There are some other things on the horizon. One that looks promising for an anti-infection take is iodine-supported titanium. So another really important thing is, how do you start lengthening? When do you start? How fast do you do it? I usually wait 5 to 7 days in my patients, but if I have a very tough deformity or I've done any acute correction at the time of the frame application, which is not typical, but we saw in that first case with the pedestrian versus MVA, I did do some correction there. So I'll have a more delayed latency period. Adults, you may not, you may need to wait even longer. And your rate. So the amount of elongation per day can be very important. I make sure that they do it 3 to 4 times a day. I really like to go slowly in the tibias and congenital cases. If you're not making good regenerate, just slow down. I'm really learning that that is a key to how I do things. Now, if I polled all of you about how you do your pin care, everyone would have a different answer. Check it, it all showed that if you put 0.2% PHMB, it's an anti-septic. Gauze, you can decrease your rate. If you can see in this, the picture of the external fixator, I use a silver impregnated sponge at least in the first week while everything is healing. I do use Olizarov sponges. Lend your makeup sponges to your patients about the same material and much cheaper. In order to keep the sponges close to the pins, I use a binder clip from our local office store that decreases the cost. So however you do it, I can't give you enough research to say we have a perfect way. So our goal is to decrease the bone healing index, to get them out of a frame faster, to get them walking faster. There are many things that researchers are looking at. Some things with some positive outcomes or low intensity pulsed ultrasounds. They're also looking into the development of a multiple growth factor delivery system for if the regenerate is not healing well. We want to prevent fractures or bending of the regenerate after all that work. Just remember that there's a 34% rate of fracture in congenital femoral deficiency. So whether you cast or brace or you supplement your fixation or your correction with rush rods, or I've been using a slim nail lately, it does not matter, but you have to look at your regenerate and be honest with yourself to make sure that you really think that it can sustain without bending or breaking. So here is a case. This is an 8-year-old who had a double level deformity correction. He has type 3C fibular hemimelia, and he's already had a super ankle. He has some deformity in his foot, which I am not correcting in this case. He was just done with the frame, and I had left him in an extra month because I didn't think that proximal regenerate was perfect. But I'm like, yeah, it'll be okay. I'm going to put him in a long leg cast. I'm going to make him non-weight bearing, and he's going to be the perfect angel and do everything I say. Well, here he is, comes out. I put him in a long leg cast, and then so disappointing. He starts to bend through that proximal regenerate. The distal osteotomy healed beautifully, but the proximal really lost its umph. So I took him back to the operating room, and I did what I probably should have done the first time, thinking that that regenerate was a problem. I should have fortified it with some kind of rod, whether it was a rush rod or a flex nail or anything, and I didn't do that. So this was probably one of the most difficult nailings I've done, and I'm happy now, but he's back in a cast, which makes him very sad during the summer. All right, so here is, this was a home run. Boy, this is going to be easy. This is an 18-year-old who had a 1.8 centimeter difference. And some would say, why are you even lengthening for that? And I said, no, this is going to be easy. This is why we have some specialized devices now that we can use. The deformity is playing into his scoliotic curve. He hates wearing a shoe lift. No problem. I got this. Well, he left the hospital, walked up the stairs of his house, and bent the nail. So now I have this very easy lengthening going on, and I have to watch it, hoping that this very expensive nail will not break. And he's a tall adult. So I got lucky in this case, but you really need to prepare for anything. And limb lengthening, again, is not for the faint of heart, and we really have to plan correctly. So this is the last case I'm going to present. You really need to have many tools in your toolbox. So this is a child that was actually treated in another institution, had 22 centimeters of length performed prior to seeing me, the ankle fusion, epiphysiodesis on the contralateral side. I knew that when I lengthened him his last 5 centimeters that his anatomic axis was in valgus, and it would probably continue that way. So my plan was to take out the nail at some point and do an acute osteotomy and put a plate or something on. Well, he really was very slow to heal, especially in that anterior tibia. And he must have been applying a lot of weight, because you can weight bear in this particular nail, to the distal screws. And he was complaining of the distal screws. There was no infection. There was maybe a little lucency around those nails, but I had to do something. So the first thing I did was I actually shortened him. I compressed that regenerate, which I think is a very smart thing to do. He was also, I think, a little too long, which may have been playing into that valgus deformity. So this is what, actually a friend of mine had helped me think through this. Again, always ask friends, get other experiences. A couple of people in the room can make your experience from 10 years to 60 in a matter of seconds, and you can get some great ideas. So I did my planning accordingly. I found the apex of my deformity. I thought, I'll just correct it. I'll do a fixator-assisted plating and all is well. But I was recommended to do something a little different. So I actually used a trauma nail to correct this deformity with blocking screws. For the sake of time, I won't go through all of this, but one of the keys is you put this diamond, this red line that you see actually is going to the skin, and you're going to mark that spot with a little, like a staple or something, radio opaque. And then you drill you put your reamers going that direction. You first put your stymon pin, then you put your blocking screws, and then you make your osteotomy. And what happens is that you're able to correct with your nail and make a straight bone. So bring out all the tools in your toolbox. Ask friends if they have other things that they really like. So I've spent a lot of time talking about pre-op planning. It is probably to me the most critical part. You know, as we always talk about, any monkey can do surgery, but I don't really think that's true. But anticipate what could go wrong, because then if you have a good roadmap, you'll never be lost on your journey. Know your patient, understand them, see what their hangups are. Is their social situation good enough to come back to your office every week? Because if it's not and they get lost to follow up, that is a disaster. Prepare their village. The more knowledge they get before surgery, even what clothes they can wear over an external fixator, what food to avoid, like sodas, etc., they will be more fit for their journey. So flatten the curve of complications. If you do all of these steps, I really think that you can come up with some pretty amazing results. So thank you so much for having me today. This has really been an honor. This is my COVID crazy team. Every Friday we dress up in some crazy outfit. And then unfortunately, I choose this picture to post on Posna, and I didn't realize that we're going to use it, but oh well, this is my family, and I will take any questions that you have.
Yes, thank you. Thank you very much for a wonderful explanation about the variety of cases and the challenges which we face during the limb lengthening and the deformity correction. Yes, we have a few questions. I would ask Kirti to start sharing the question. Kirti, please. You need to unmute yourself.
Yeah, and Kirti, also start your video so people can see you.
My host has stopped the video, so host has to do it.
Yeah.
You can
We'll do
start
that.
speaking, Kirti, meanwhile.
Yeah.
We'll get the video.
Thank you, Dr. Nicole, for a lucid presentation. So Dr. Taral Nagda has asked a question. What will be your indications for prophylactic fasciotomy? When will you go for a prophylactic fasciotomy?
For tibial lengthenings, I will tell you, I couldn't find the discussion, but I had thought I had heard someone say, oh, well, we really don't do that anymore because some people complain about the hernia that you could get over that anterolateral compartment. But then I had another person whisper in my ear saying, I just had a compartment syndrome. So two things. Number one, if you have one thing to think about, if you're doing whether you're doing a fixed or assisted lengthening with a nail, if those reamings as they go out the back, if you're reaming for a nail, you may want to vent the bone anteriorly instead of posteriorly to try to decrease your risk of posterior compartment syndrome. I typically, honestly, I think I haven't done an anterior fasciotomy about once. And now that I've heard more people talking about compartment syndrome, that is just a risk I don't really want to take on. I just think there's so much to think about. So I generally do an anterior fasciotomy in my tibial osteotomies.
So Dr. Rajiv Nigandhi, he has 4 questions. So I'll put it one by one. First is, what's your youngest age to start lengthening? Youngest age?
Youngest age. So the child with the fibular hemimelia, I did his first lengthening at about 3. I'm not sure. I've become much more, I really talk to the family, when I trained with Dror and John, they usually do their first lengthening either with the super ankle or they do it at age 4 so that they can equalize their limb lengths before kindergarten. I'm not sure that that's important. And I think that listening to the families when they're ready to lengthen is appropriate. And also you can kind of feel with the child if they're going to be able to tolerate that. So I do think you can lengthen early. I will tell you, I've started to push the envelope a little bit later to begin my lengthening because I think they can participate in physical therapy a little bit better.
So the second question is, he wants you to speak on upper limb lengthening, tips for upper limb lengthening.
Do I have to? I have not, honestly, I don't think that I am the right person to talk to about that because I have an upper extremity specialist here that I don't see many of, for like the TAR babies go to her. She spoke with you guys a few weeks ago. I've done some, I just haven't done enough to comment. They keep me in the stinky feet.
Yeah. And your views on lengthening in achondroplasics and cosmetic lengthening.
So interesting that, training with Herzenberg and Paley, I didn't think twice about lengthening an achondroplastic dwarfs. I thought it was great. That was what you should do. Now I'm here at DuPont and Will McKenzie does more alignment surgery because he is very involved with the little people of America. So I've seen now 2 very different perspectives, and I do think it matters what the family wants. Some people say, should you be lengthening a child that really can't speak to what their desires are going to be when they become adults? So I think it's a very personal decision. I have no problem doing the lengthening though. And for cosmetic lengthening, I actually just did a talk for POSNA about doing very small lengthenings, very, like 1.6, 1.8. And is that okay? Or should we just make sure that they have an epiphysiodesis or just force them to wear a shoe lift? I'm 5 feet 4 inches tall. When I speak, I'm 5'8", I hope. But I'm not, I'm really short. And I think that when I was doing this talk to compare epipsiodesis with these, very short lengthenings with the nail, I read some stuff on the psychology of height. So I think for me to say that cosmetic lengthening is not necessary, we should never do it, is probably not true. It's a big financial investment. And certainly things can go very, very wrong, but things can be very, very right too. And I think we're getting safer technologies. But as I said in this whole talk, if you ignore the principles, even when you're doing a 3 to 5 centimeter lengthening or less, you're going to get into trouble. So education.
I want to butt in with a couple of questions related to this, Reed.
Sure.
One is, in India especially, where we are not very, our infrastructure, etc., is not very appropriate for differently abled people. And in achondroplasia, the lack of height is certainly a challenge, So
Yes.
whereas in the US, you have, you can have your home kind of built to,
Right.
for your height. So generally over here, in situations where that kind of help is not available, would you kind of change your outlook in terms of achondroplasia?
My outlook is
What is
that
the argument if the patient is willing?
yes.
When I was doing my fellowship, the LPA had kind of agitations against Dror and John for lengthening achondroplastics, with saying that you are telling them that they are abnormal and all that kind of stuff. But I think it's a pretty safe thing, and it helps them.
Yes, I think the world in the U.S. is made for people that are 5 feet tall. I have no issues with lengthening achons. I really don't. Here, I just am a little bit quieter when I say that. But most people come here because they want angular correction, not necessarily lengthening, because of Will's connection with the LPA. But I agree. I mean, I think especially now that we do know how to do lengthening pretty well. We certainly have, we haven't minimized the risks, but I think that things are getting a little bit easier to do it. We've, our people that have come before us have made some mistakes that we learn from. And I think our devices are getting better. They're still expensive. So I agree with you. I think it's a family choice. And if they want to be lengthened, I see no problem with it. As long as they're being lengthened in a proportional way, because they can look kind of funny. I had a girl that came in with a pair of boots on, and I said, "What is your problem? Why do you want to be lengthened?" And I said, "You look tall. You're above 5 feet. I'm not much taller than you." And then she cleverly took off her shoes, and inside she had a wedged flip-flop that was she had a heel this high that was stuck in her shoes so that she could look like she was taller. So I think the psychology of height is important, and if it's something that's important to you, there's no problem.
Right. And the second question related to that was for cosmetic lengthening. We have now the implantable nails available. I've done, I think, 5 cases where we've done cosmetic lengthening in adults. But would you, if you have a patient who cannot afford implantable nail, would you, and very much wants cosmetic lengthening, would you do a cosmetic lengthening using a frame?
Well, okay, so I will say in one case that I had in fellowship makes me question whether I do that with a frame. because the scarring from external fixators is much more significant than the implantable nail. I mean, there's still holes, but it's much more obvious. It depends on the psychology of the patient. If the patient is very fixated on what the scar is going to look like, then I would say no, I wouldn't do it, because this child had come from, or he was an adult, but he had come from another country. He had been lengthened multiple times, and he was absolutely obsessed with the scar. Now, his tibia was way too long compared to the femur, and Dror just told him to just pull up his pants and he would look better, because he was obviously mentally challenged by too many parts of this, that I think you have to be very careful. You know, it's not impossible, but I think I'd be more reluctant.
Yeah, I agree. I mean, having done a few with this nail, I don't think I would do a cosmetic lengthening with a frame. It's just too much trouble.
Much trouble.
The patients are, they're difficult patients. You know, they say that, you know, how can you get normal, more normal? If anything, they're going to lose something in terms of function. And with a frame, to do a lengthening is not a good idea, because sometimes they want unreasonable lengths. So yes, if we have, as and when in India it becomes available more freely, it's very expensive for India right now.
Yeah.
But that is probably the only thing that we should. The reason I bring this up is because oftentimes this is one of the reasons why people will approach orthopedic surgeons, that I want to get length, I want to gain height, and relatively inexperienced the people with lengthening will oblige the patient. So cosmetic lengthening is actually the apex of Elizarov surgery. It's only after you've had enough complications at the base of the pyramid that you should be doing cosmetic lengthening. There are too many complications.
Well, that's why I told you that silly story about someone who I trained with, and fabulous surgeon, but was so proud to tell me, oh, I put the first lengthening nail and I beat you. And I asked a very simple question. Did you lengthen the IT band? She had no clue why I would ask that question. And that is one conversation. You know, I know that you don't have as many intramedullary lengthening nails over there, but boy, I was just operating a fabulous fellow that we have right now. But the first thing they said to me when we were doing we were putting in a femoral lengthening nail, you know, it's a solid nail. I have to make the ostomy. She's just like, oh, it's just like putting a trauma nail in. I put plenty of those in. I was like, oh my gosh, what have I not taught you? And then, you know, I won't sell that person out, but the resident and the fellow needed to hold the leg so that we wouldn't lose the reduction. And, you know, things happen, and it just made it a longer nail insertion. But if you don't know your device, and you'll see how dangerous it is when these become super available in India, it is amazing. You're listening to these people saying, oh, I can do this, I can do this, I can do this. And they're not sticking with the principles.
Yeah.
And, you know, they get tight. You know, especially if it's a congenital and all of a sudden you have a hip dislocation. It can happen to anyone. Feldman has presented some great talks on, you know, 1 to 2 centimeters of lengthening and the hip pops out. That's a big problem. And if you don't know how to recover from your complications, that's an even bigger problem.
Absolutely.
Luckily, I have friends here.
Kirti, next question.
Yeah. So Dr. Atul Bhaskar is asking, if you get a poor regenerate rate while lengthening, do you use a bone marrow or BMP to augment it?
So I have not had to do that. I think that compressing or slowing down as you're seeing that regenerate is really important. There's nothing wrong with doing it, but I actually have not done that yet because I've been able to save the regenerate either by slowing down, taking a break, even though mentally that is very challenging for both the family and me. You know, if you're saying, you've got a really big deformity and they're going to be in a frame for months and months, like that child with fibular hemimelia. Clearly, the regenerate was not ready for me to remove the frame. It wasn't. There's a big line right through it that tells me something is going wrong. And I just didn't want to listen to it because the kid was annoying me and he was ready to get out of the frame. I might have benefited from going a little sooner and putting, injecting something. But I think that shortening and compression or just slowing down before you get to that spot is a better idea.
Any role of bone marrow aspiration for a better regenerate?
I think that there is probably a role. I mean, they're doing, Jobst just put out it was in 2015, I think, looking at advances in limb deformity. I mean, yes, they're looking at different what I had said in that one slide was, if you can get a cocktail that has a very good way of putting it into the regenerate, that would be a great idea. And I think there is research going on for that. But the less you have to put in and the more you can use your own body host, I do think that the child with the pedestrian hip, the mentor that sent me that patient is the #1 person who tells me always to look at the nutrition status and the vitamin D level. I mean, that kid's vitamin D level it was nothing. And once we got the whole host back to where it needed to be, that really did help to heal things.
Kirti, let me just butt in there. I've had a few of these, delayed consolidations, and the most important, as she pointed out, is to monitor the regenerate. Lengthening is not a surgery, again, which she pointed out, that you put on the frame and then teach the patient to distract 1 millimeter per day and then come back after 60 days when the length is achieved. No, they have to be monitored at regular intervals. And depending on how the regenerate is performing, you may decide to slow down, or it's better to decide to slow down the regenerate, so you're less likely to have trouble. In spite of that, sometimes you have trouble. Now, the ones that I have done, they've always had, I do an ultrasound to look for what is there, and there is usually fluid inside. When I open it, there is a membrane which lines that cyst. So I personally don't think that bone marrow injection is going to work. What is happening here is, this is a patient who is already getting a little irritable in terms of how long this treatment is taking. So whatever I want to do now, there has to be no if and but about it. So for me, opening that up, curating out the membrane through a small incision, just like the corticotomy, and then packing it with cancellous bone graft is the thing to do. Once you find a defect in the regenerate. If you are, it's not ossifying well, but you can see sort of lines on the medial and lateral side, anterior and posterior. There, yes, you just slow down and it will catch up. And all the other stuff, vitamin D, nutrition, that kind of.
I usually say vitamin D is not the only answer to bone health, but it's a really easy thing to give, and it's very hard to get in your diet. So I have a spiel for that, but I think you're right too. And I think sometimes when you're lengthening and you're correcting these very large deformities, you might have a multiple osteotomies. It's hard to be very objective in what your outcome is. So you have to be true to yourself that regenerate's not looking so good at, 6 weeks into this. And you need to change something. You need to change the rate that you're elongating. You need to go backwards. You need to take a break. But I think that being honest with yourself that it's not going quite as well as you think it is may save you a problem at the end.
Is there any role of local stimulation techniques?
Yeah, I mean, I presented that briefly, that there is some positive results for ultrasound and some kind of e-stim. Not perfect, but looks like it does. The stimulation may help, but I think more research is going on with that.
I've used it in a sort of belts and braces approach. I will graft it. If the patient can afford, then they will get an e-stim. but I wouldn't rely, the data doesn't support the use of e-stim alone. So, all right,
Mhm.
patient can afford, and I want to do as much as possible. Patient can afford it, use it, but not alone. Especially in
Is it
our
hard?
situation, it's not easy to get it.
Is it hard to get e-stim over there?
Yeah, they
Oh,
had it earlier,
it's after it
but
here.
now the patients have to kind of, someone coming from the US will carry it for them, kind of thing. That's how it works now. It's not
I mean,
available from them here.
the CFD patient that I presented, literally, it took us 3 months to get the e-stim. The day the guy had come to the hospital to deliver it, we got an X-ray and it was healed.
Mhm.
But it's painful because I had actually taken her back to the OR to take out her A plates because her knee, her alignment was corrected, and that thing was still not healed. And I was going to take it down and put a plate on and bone graft it. And Mahir and I talked, and we're like, you know what? It's a big surgery. She's not nutritionally stable yet. Let's not do this. And so luckily, it worked in our favor, and she finally healed. But that knee is going to be a whole nother story. That's got some stabilization issues.
Right.
I go ahead.
Dhiren, yeah, any more questions, or we can go on to your
there are many questions pending.
Okay.
So what is the threshold for knee contractures while you are lengthening the femur?
One, look at what your knee range of motion is before you start. If you need a rectus release, some of us are using Botox. I use Botox in that one child with the hoverboard. If I go below 45 degrees, I'm definitely stopping and slowing down. So I'm pretty aggressive at making sure, and 45 is, that's pushing it. I like them to really, I don't want them to lose it all. So I tell the family, as I'm preparing my village, that PT is not an optional thing. Home stretching is not an optional thing. And if I need to do preparatory surgery before we start, I'm going to do that. If it gets too tight, I tell them I'm going to go backwards, and you're going to lose some of your length because we have to maintain our soft tissue envelope, or the knee's going to dislocate, or the hip's going to dislocate. Something bad is going to happen. So I'm pretty adamant about that.
Yeah, getting a longer limb at the cost of function is not a winning proposition. So you have to ensure that there is good therapy going on. Luckily, now we have one of Anil Bhave's 2-hour lectures on the net. So even people whose therapists are not used to that can look at that and see how things need to be treated. There's a lot of work that goes into that.
I don't know if Anil's brace has come to you either. I mean, his bracing techniques are really good. Anil's a magician, and there are lots of things that you can do to try to save a knee, but good therapy techniques. I think Fran, one of Dror Perley's physical therapists, has a fantastic talk on how to manage soft tissue. So the other thing that I've noticed is a really big benefit is to have your therapists be very well educated in what they're doing. So people that have trained with Anil or trained with Fran, or I have a really good therapist here, that is important because sometimes they don't understand what surgery you did and what the goals of their therapy are, and why going once a week is not going to cut it when you're trying to achieve 7 centimeters of length.
Yeah.
But
so
don't
occasionally I have a similar issue where we will send patients to the custody of a therapist closer to home, so they don't have to come. But when they come on the follow-up, they're not doing what is needed. So the first thing to do would be to speak to the therapist, get my therapist to speak to them and see if they can understand what's happening. If it's not happening, then sometimes the patient may need, to get admitted for 5-7 days to get good therapy here and then go back and continue that. And luckily now with WhatsApp and stuff, they can, keep a follow-up by video with us, with the therapist, So I can see, is he walking properly? Is he mobilizing properly? And if that's not the case, then they need to come back, despite whatever it may be in terms of distance and all that. That is something. And usually the advice I give to patients in terms of, I treat quite a few outstation patients. So how long am I going to stay in Mumbai? And that's going to be the initial period of lengthening. You're definitely going to be in Mumbai. If you are doing well, if your exercises are going well, your ambulation is going well, your pin side care is going well, then we'll send you home. And you can follow up from there on video. But if it's not, then you would need to stay in till the lengthening is over, because that's the time when all the issues happen. During the consolidation phase, there's no problem. So, you know, I try to ensure that during the time that they are likely to have trouble, they are closer to me and not very far away.
Limb deformity is a team sport, and the center of our team is the patient. But if we don't have good communication among all the players, you won't have as good an outcome.
So is there any role of manipulation under general anesthesia if you find that your patient is getting stiff while lengthening?
I would prefer to be able to either back them up, you know, shorten what you've gotten so far, work on manipulative techniques. I mean, sure, I think you can, I don't typically have to go back to the OR, but certainly you want to know what's causing that problem. Is it a pin that's too near a nerve that's irritating them? Have they lengthened too fast? Do they need any other, is there physical therapy going well? I don't know, you guys can maybe answer that question too. I mean, I typically don't have to take them. When I'm in the OR though, let's say some of my fibular hemimelias, that one that I showed you, you know, I worked on his knee before I took off the frame because he liked to hold it externally rotated and flex to 90 all the time. But I had a brace on him so that he wouldn't do that. But I will tell you that when I finally went to take the frame off, before I did that, I did manipulate, but it was only because I had a 10-degree flexion contracture.
Yeah, otherwise in general, to achieve flexion, I think manipulation is the wrong thing. If a patient is getting stiff, there is some mismatch in the lengthening, in the physio. And there are times when you have to call it a day that, okay, I will do this lengthening in 2 stages. Yeah. One of our problems is that at young ages, patients get told, oh, okay, wait till you're 16 and then we can do the lengthening in one go. And I have to tell patients that, no, I am going to do your lengthening in 2 or maybe 3 sessions. I'm not interested. It's better to have multiple small lengthenings in terms of function than to have one long lengthening. And that is something which still is prevalent in our situation where, okay, you know, wait till you're 16 and your length discrepancy is stabilized and then we will lengthen the whole thing. No. Generally, I would prefer to have physiotherapy. If that doesn't work, then surgical options once the fixator is out to correct this lengthening. Manipulation under anesthesia, I think, is not. A lot of equinus deformities which develop during lengthening, despite putting on a sandal and straps, they respond very well to the patient stretching. And this is what she was talking about, Anil's splints, or constant extension force on the knee joint to correct knee flexion deformities. Prevention more than correction, but even if it does happen, constant stretching at home, I think does better than a stretching under anesthesia.
And you can
So
break
I don't
things.
do it.
I mean, yeah, I think I only do the, you know, at the end of lengthening, but before I take the frame off. Like, you cannot start manipulating that new regenerate. That's another thing I'm very careful with, when the way and this is definitely a Herzenbergism, very, very careful about the way I take off that frame, making sure that the people that are training with me know that, hey, it's a simple frame removal, but if you hold the leg and you just sort of hold it by the toes and we start to bend through that regenerate, that would be a problem. So, you know, teaching even the trainees the little details about limb lengthening and you know, just as simple as taking off a frame can be trouble. The other thing I was thinking about is if the intermedullary lengthening nails come to you, another thing that I think some people may overlook is you can't brace or you can't put like the sandal splint that you would put on the external fixator to hold the foot from getting that equinus contracture, but you have to put a brace on, an ankle foot orthosis, something. Whether you're doing, and if you're doing a femur, I usually put a hinged brace on that I can lock out at night. So you're not bracing. That is one of the critical steps so that you don't develop a contracture.
I agree.
Okay. So is there any role of shortening to treat limb length discrepancy?
Of course, if that's what they want. As a short person, I have to be very careful that I'm not biased when I'm talking to these patients. So my best example of that is I had a child who completely normal, just had an idiopathic limb length discrepancy of 3 centimeters. She's not of great stature, but she did not want a shortening. I mean, she did not want a lengthening. And I said, okay, you're going to be, you know, shorter than me. And she said, I don't care. It would be easier. And I told her, I'm like, you're going to have to I'm going to use a nail to do it. Are you okay with that? Yes. The next patient I did that day was an Orthopaedic child with a hip dislocation with a limb length discrepancy, could not stand wearing her shoe lift. And I was thinking, well, it would be perfect for me to shorten you and lengthen the other girl, but I ended up lengthening the Orthopaedic child who very slowly, very, very slowly, and shortening the other one, and they both are happy as can be. Neither one wears a shoe lift, and you know, luckily in that case, there weren't any complications. But yes, I think that it's a personal preference, and I definitely do a lot of epiphysiodesis. I am using, even in the deformities that are less than 2 centimeters though, I do give the option of both shortening with an epiphysiodesis. If they're skeletally mature, I will talk about just fixing the shoe or doing a shortening. And the third thing is now I feel pretty comfortable saying I can lengthen your leg for a small deformity too.
So any red flag signs on an X-ray which will tell you that this might go for a fracture, the regenerate might fracture or it might bend. And second part is, what red flag signs do you tell the parents to look after and come back to you just to prevent the complications?
For the regenerate, I mean, there are many ways that you can measure the quality of the regenerate. So you can use that. I look for the cones. I look for how many cortices I have formed. I look for cyst formation. I look for asymmetry of how the regenerate is forming. In my fibular hemimelia case that I presented, there was a line from where I externally rotated the foot. And I think that should have been a better telltale. It just was not, there wasn't uniformity in that regenerate. In terms of telltale signs from having a patient at home, they are very well educated on what to look for a pin track irritation versus infection. I am able to prescribe via the internet antibiotics. They usually send me a picture and I say, I don't like that. If they're having pain that's unusual, I mean, especially now I use a lot of Tylenol, and you know, we've had a huge opioid epidemic here. So we really are very, we're finally getting smart about how to prescribe opioids. So if they're all of a sudden needing more pain, that is a red flag sign. If they're having fevers, also swelling, bleeding around the pin site, or if the family sees that the frame does not look like they first thought it would. With the very large child that with Blount's, his frame, the whole thing shifted up. And I looked at it, I said, that is not right. The family hadn't really noticed it. They thought it looked a little different. I don't know how you miss that, but it happens. So fever, pain increasing despite giving medicine, and the overall alignment of the leg changing would be big signs. Or if they can't straighten or flex their leg or ankle, or the hip hurts.
Yeah, today all of these situations anyway, the patient and the parents get worried, so they're going to contact. In fact, when I started my practice, when mobile phones just came out, I had my mobile phone number on all my visiting cards, so that if patients need to contact me, because at that point in time I was like a single resource for the patient, so they should be able to contact me whenever needed. And those were the days when even incoming calls were charged $16 a minute or something like that. But no matter, they should be able to get in touch with me in case they have any worry. And I would tell them that I would rather you call me and with a sort of false alarm, rather than sit at home and worry about, should I do this, should I do that kind of stuff. Today with WhatsApp and everybody having this thing, it's hardly a problem. They themselves will, take a picture and send it to you. Doc, this is what is happening. And then, like she pointed out, I would start with, if it doesn't look like infection, start with anti-inflammatory for a couple of days, see if that settles the pain. If not, then antibiotic and stuff. So you can do a lot of looking after the patient, caring for the patient now with WhatsApp. And we've been doing a lot of these so-called teleconsultations even before COVID started, because patients are far away, and we want to keep monitoring them, because all of these things are important. Patient goes away, lengthening is completed, but patient is not walking well. He's going to take time for that regenerate to consolidate. So X amount of time has passed and patient is not walking well. I'm worried. I see to it that he or she starts walking properly. Why they are not walking? So all of that, I think there's not so many red flags in the sense that all these other troubles which patients have, they will themselves come and complain to you.
I agree with you. All my patients still have my cell phone so they can get a hold of me quickly, because I don't think my residents that are in the hospital have as much knowledge as I do. They weren't typically in the case. I don't want the...
Sometimes they're not as invested also, in the patient.
Yes.
The way we are.
So Reed and Mangal, I just wanted to discuss one approach, so people have a high rate of complication with lengthening. So what we did, we had a clinic manager who's a, simple nurse who is given responsibility of calling up all the patients once a week. And she will note down, do you have pain? How is the range of movements? And they will send her photographs of range of movements on WhatsApp. And we found that we were able to pick up some of the complications even before the patients complain. So, this is a proactive approach, and second can be a reactive approach, having patient complain to you and then you act on it. So do you think it would...
I start my proactive approach in theater, in the sense that a lot of stuff which can cause pain later on, for example, skin tethering, etc., I will spend half an hour extra in the theater, because I know if I don't get this right, I'm going to have trouble with the patient calling me back later. In addition, of course, proactively, if a patient hasn't contacted me for a while, then we will try and find out, okay, it strikes me, why hasn't that patient called? But yes, what you say is also a good approach. If you have somebody who's constantly, sort of regularly calling patients to check, we've not really had that much of an...
So we picked this up from the Ponseti approach, Ponseti approach, where they have a social worker who will call up the patient who defaults. And we found it good for this and growth modulation both, because patients do default and they do take
That's
things
the
like
worst. Growth modulation that doesn't come back. I'm like, how could you, didn't you see his leg was going the other direction? But I agree with you. I do bring patients back. It's beginning to be a little bit more difficult. We're not seeing as many patients in the clinic per day, and I can't sneak one in because of COVID and the regulations of the hospital. So I usually see patients every week. I'm now stretching, I got to stretch them out to 2 weeks, but that really stresses me out. So I like your approach. I think it's great.
Now that we're talking of COVID, it would be interesting to know a couple of things. One, what patients are you doing now? Are you doing electives? Number two, do you do preoperative testing for COVID in these patients? And three,
Yeah.
what is the kind of PPE that you use for these patients?
So we're pretty much up and running. We in the beginning we broke down into 4 teams. So 3 teams were at home doing telemedicine, and we were pretty active in telemedicine, but it just ramped up by 1,000-fold once COVID started. So we really broke down things. We had a triage nurse. We had people getting siphoned into an urgent clinic and kind of an operative semi-urgent, very urgent clinic and an urgent clinic. And we were allowed to do some cases that were necessary. And now they have made the days longer in the OR so we can operate a little bit later. Every single patient that is going to have surgery will have a COVID test within 72 hours of coming to the hospital. We have a separate COVID operating room, and there's a whole protocol that goes in it does change every day, so don't ask me too many details on how that patient we had a skiffy the other day that was COVID positive. And she had to be put on a special floor. She was taken to the operating room the next day after into a room that is only for COVID patients. So that's how that's happening. In the PPE, the surgeon's not in the room for the intubation of a COVID positive patient. They have face masks, I think in N95s in the operating room if the patient is known to be positive. If they're not positive, if we are doing a semi-elective or elective case on a regular patient that's been tested negative, we use just your typical eye protection and mask.
Eye protection as in a visored mask?
Yeah, and I wear a mask all day. The CDC regulation or suggestions now really push us to wear eye protection in the clinic, which I probably should have been doing all the time because you never know who's positive. And now people are a little bit, in the US, people are pretty much thinking that COVID went away, even though our cases are rising still. So I'm not sure. What was that?
You don't have enough bleach in the US? Your president said?
No, but we do have injectable bleach and UV light that is really good for us. But if we don't have that, we have hydroxychloroquine, no problem. Okay. Oh my gosh.
No, my question was for these non-COVID positive patients. There you use standard stuff.
Standard.
But there is about a 30% false negatives, right?
Yep. So you still are relatively protected with your regular surgical mask. I won't let anyone in my operating room without eye protection because I think it's not very smart, and I think it's an OSHA regulation. I'm not their mother, but come on, like when in the first weeks we had a child that was from a very high COVID area. And I watched the anesthesiologist looking over the child without a mask on. And I said, what are you doing? I know we're just putting a spica cast on, but you're intubating the patient. Oh no, the fellow's intubating. I'm far enough away. I'm like, you're 1 millimeter away from that patient's mouth. Are you kidding me? So I don't know, everyone to each his own, but I am trying to be very diligent about eye protection and masking and protecting my trainees.
Okay, get back to lengthening now.
Orthopedics.
So, yeah. So what is the role of oral alendronate for a poor regenerate? And secondly, what is E-stem? The audience wants to know what exactly does the E-stem do?
So starting with the bisphosphonates, I do not think there's, in the Yopes paper that I just reviewed, I don't think bisphosphonates alone are we can say that that's your best for regenerate. It blocks your osteoclast from functioning, but I'm not entirely sure that that's enough. So some studies showed using some bisphosphonates and BMP. Again, I'm not an expert on this, just because I haven't had to use it. So I think you have to be careful. I think that there are other things that you can do before using those bigger drugs. And if one of you've had more experience with using bisphosphonates and lengthening, I have with CPT, I definitely use them there, but not here. And I think you guys had a talk from Dr. Paley on CPT recently.
Yeah.
I think that procedure is great. And then I throw the whole kitchen sink, the BMP, the bisphosphonates. But in lengthening, I'd rather look at both the patient that I'm trying to lengthen and trying to figure out what's going wrong. If it's something as silly as you've got, 2 grandparents in the house smoking, that's that's an easier, less expensive thing to change. What was the second question? Oh, the E-stim.
E-stim.
Again, something that I have not personally used, but they're trying, E-stim typically tries to bring blood supply to there and increase with the electricity to have bone cells heal better. But I don't think alone, I mean, there's some promising studies, but not, I would try to fix the problem before I went and put that on as my sole reason, sole way to improve my regenerate. Maybe somebody else has more experience than I do with that.
No, I have, this is what electricity, not the ultrasound.
Right.
No, I have no experience with it. And I that's why a lot of these so-called allied pharmaceutical and other interventions, I am very, very wary of, because industry in general is not interested in the patient. They are interested in the patient as one more bakra, one more thing that we can put our product into. So when industry comes out with science, you have to look at that very, very skeptically. I am not a big fan of. Yes, we have to work with them and cooperate and get things together. But otherwise, a lot of these things I think should be looked at skeptically, because they keep going into a circle. Ultrasound, once upon a time, it's the next best thing after sliced bread. Then it is useless. Now again, it's kind of, they're trying to show as if it works.
And I think that going back to those, if we go back and just think, what would Elizarov have done? If we go back to the principles and we make sure, is it an alignment issue? Is it a stability issue?
Stability, yeah.
Is there an infection issue? If you jump to the, well, how can I fix this by giving them a drug or putting a device on, and you don't fix the problem that is causing this issue with the regenerate, then you're going to come up short. And easy is not always best.
So one minor complication I have experienced while putting a femur frame is the proximal most shank spine, the wound gaping occurs very frequently. The rest of the shank spine won't gape, but the proximal most will gape without any infection. So how can I prevent that?
So, I mean, I think you see a lot of fat necrosis in that area. I mean, I'm not pushing a product and I'm not saying like I said, if I interviewed 10 of us, we would all have different pin site, pin care protocols. But in that area, I watch very carefully. I make sure that if the pin is here and this part's in the bone, I don't let them push the skin away from the bone, especially because I use HA-coated pins now. So that is actually, our physical therapists teach them how to do pin care. And I had to make sure I got to all the physical therapists who were teaching, make sure you get every bit of crust off. And I use a lot of silver dressing. I think it's very easy to put on there. The one I use is, it's called Mepilex AG. It's a foam, it's a sponge that has silver in it. And I think it's absorptive and can help decrease. The other thing is, taking gauze and decreasing the friction, either gauze around it or a sponge. I don't know if you understand what I'm saying. There's those Alizarov sponges, which are very expensive, are really the same material as if you go to a store and buy a makeup application sponges. And I can tell all of you use makeup all the time, you're putting your foundation on. But if you did, these sponges are great because they're absorptive. You can wash them, and you can put them along your pin, and they can decrease friction.
Yeah, one of the things that I do is the issue is that your skin is there, and it keeps pistoning in and out, as well as there may be up and down motion. Now, if you restrict the movement between the soft tissue and the pin, you are less likely to have that kind of trouble. And one of the things I use is ask the patients to buy small Turkish towels. Turkish towels, because they are kind of bulky in terms of, and then after they've done the pin site care, wrap that pin with a Turkish towel. So the Turkish towel basically takes up the space between the frame and the skin, pushes the skin a little away. So if you have multiple strips like this, they can be washed and boiled and reused again, just as a stabilizer, like Reed was talking about the foam. You can use foam.
And I use this, see this binder clip? This is a big one.
Yeah.
And I can put that on the pin and slide it down to hold a Turkish towel or a sponge in place. And it costs about a penny each. And this is actually a makeup application. It's in a funky shape, but this spongy material, if I cut this, or I found ones that were circular, it's the same thing. It's just not medical quality, but if I use the combination of that and these, it works.
Principle is reduce pin skin motion.
Yes.
So the last question is, can you do a bifocal lengthening with a nail?
With a nail? Well, I don't usually do, so you could do a transport, but that's shortening one side and lengthening the others. I don't think I've ever tried that. I have definitely done deformity correction with an acute osteotomy and a plate fixation distally. I didn't use this example. I was trying to get the precise nail out of the picture as much as I could, but we use a lot of them. And then I'll do a proximal lengthening. That is definitely wrought with some problems. You need to anticipate where your deformity is going so you can have a perfect outcome. But I have not, I think if you do a fixed or assisted lengthening, or a lengthening over a nail, you might be able to do that. I have not personally done.
And I don't really see much advantage for it also. One of the advantages of bifocal lengthening is that, yes, time may be saved. But if you've got an internal device, which is not really giving you trouble, I don't think it makes too much of a difference whether it's taking 1.5 months or 3 months for the lengthening to complete, because patient otherwise is pretty comfortable, pretty functional. So maybe it's a solution in search of a problem, really.
I do a lot of bifocal lengthenings and with deformity correction, but in things like fibular hemimelia, where I feel like there's deformity, there are 2 levels of deformity, and I can do a little bit of correction, but usually there's one place that is really being lengthened.
Yeah, that's the lengthening place. That's right.
Yeah,
and the deformity side you do
just deformity.
less.
Anything I can do to minimize problems, because some of these deformities, especially on these arthropodic kids or neurologically impaired kids, they're tough, and I want it to be simple. It's never simple, but I try.
So, Kirti, any more questions?
No. Questions are.
Of course, questions will never end, and
Yes.
so there are questions to which there are no answers. But I suppose we need to
some good thought.
End this webinar. So, Reed, thanks a lot. Because this is one topic which can actually become a pandemic. There are lots of lengthening which take place, and if you really don't take care, nothing stops it from becoming pandemic. And what really is required, you give us all the recipes to prevent the pandemic. One is lockdown, put a very stable frame. And as Mangal and you said, the technique really starts, the prevention starts in the operation theater. So lockdown in the operation theater, very, very important. And restrain. Restrain is very important. Restrainment. So don't do big lengthenings, do small lengthenings. And containment of the skin by preventing the skin teethering and putting dressings well and taking care. And very important thing is the surveys. The surveys people do. You talk to patients and find out. Give them your phone numbers. Very important tip we got from both of you. Patient should be contactable. So if a small doubt exists, you pick up the complication early and treat. And finally, if we do all this, certainly it will flatten the curve. And we must remember it will flatten the curve, but complications are there to remain, like COVID. And we must take care of them in the beginning so that we don't face the lockdown. So thank you very much for a very interesting webinar. Thanks, Mangal, Kirti, and Vivek. Very, very interesting. And after learning the complication, maybe we'll now learn how to put the frames when John Hasenberg talks to us next time. Thank you very much.
He's the best. He's the best. So thank you. It was really an honor to be part of this. And I want to jump on to the John Herzenberg talk. He really is a fabulous teacher and truly who I've really tried to make him as my mentor and role model. So thank you all so much. And it was nice to meet you all virtually again. Some of you I've seen before, but hopefully we'll see each other at a live meeting soon. And thanks.
Thank you.
And before we end, I just want to mention that if you have missed any POSI webinars, they are all available on POSI website, www.posi.in, and they are also available on OrthoTV online.com. So you can still visit them anytime you want. And with this, we end this webinar. Thank you very much.
Thanks all.
And let's thank Ashok and Neeraj for their wonderful help. Thank you, Ashok and Neeraj.
Thank you. Bye-bye.
Bye-bye.
Dr. Nichols, do you want us to send you the link of Dr. Hasenberg's webinar when it is there on 4th of July?
Would you mind?
We'll just mail you the link.
Okay, fantastic.
Okay.
If any and if any other questions come up from anybody that I can possibly answer, please, feel free to use my email. It was really lovely doing this. Thank you for the opportunity. And this is a fun conversation.
Thank you. Yeah. Bye-bye.
All right.